I'm Dr. Mabel Mardones. I'm a breast medical oncologist with Rocky Mountain Cancer Centers in Denver, Colorado, executive committee member with Sarah Cannon Research Institute. And I'm joined today by my esteemed colleague. I'll let you introduce.
Hi, Mabel. Good to be here with you. I'm Joyce O'Shaughnessy, breast medical oncologist at Texas Oncology and the Baylor University Cancer Center and the SCRI Trials Network in Dallas, Texas.
And we're very excited to be talking about such an important topic today, which is the new approvals of T-DXd in both in the neoadjuvant and adjuvant setting. So we've moved away from anticipation now to action. And so these are sort of the topics that we all want to hear about, which is how are we using T-DXd and what are the most common barriers that you think community oncologists are going to be faced with in thinking about T-DXd in general?
So thankfully, we're very familiar with T-DXd from the metastatic setting. You know, it's like pretty much every patient gets T-DXd at some point in their metastatic journey. So we're very comfortable with it. But now we, with our new FDA labels for stage 2-3 of breast cancer, HER2 positive breast cancer for the preoperative use of 4 cycles of T-DXd followed by THP, and then from the DB05, the broad label of any residual disease, we really have good leeway to think about bringing that in. And our stage 2-3 patients, probably by and large, will get T-DXd. I think that's really the nuance is going to be for the lower risk T2N0, you know, for example, because in DB11 it was T3N0 was the eligibility criteria, but this is a broader label of stage 2-3. So we have some leeway there, but the good thing is if we decide for a lower risk individual to just go with a classic TCHP or more rarely an ACTHP, we can always bring in the T-DXd if they have residual disease, you know, after surgery. So I don't see it so much as barriers. It's just I think it's going to take us as a community, I think, a little bit of time to see whether is it going to be kind of like anybody who's eligible, both in terms of comorbidities and other, you know, their overall health, and also eligible for receiving it per the labels. Are we going to give it to everybody up front? And I'm just curious, what do you think?
Right. So I think that for my node positives, I'm clearly going to be using this strategy. I'm impressed by the PCR data, particularly for the ER positive group. But you bring a good point, which is we see a lot of T2N0s, at least in our communities. I treat a lot of young women in my practice, and they're doing their screenings, they're coming in, and those may be strategies or patients for which I might do a modified approach, where I might think through switching the approach instead of starting with T-DXd, or another group of patients that are elderly patients who I'm concerned about their toxicity profile. Can they even handle chemotherapy at all? Mm-hmm. Is this a group where we might do an adaptive strategy where you might do taxane, HP followed by imaging, and reassess, and then give them their T-DXd? Obviously, that is not the way the study was done. But in my clinically node positive and larger clinically T3 tumors, I'll be doing as the study did, which is starting with T-DXd up front.
Yeah.
Is there a group of patients, Joyce, that you think should not get this treatment?
I think any history of ILD, patients should not get the T-DXd. You know, for example, patients who have had, this is not pertinent to the early stage, but we know in the metastatic setting, if patients had ILD from other therapies, that they're at higher risk from getting ILD from the T-DXd. So I would not take that chance in the curative setting. And I think patients with, you know, very substantial comorbidities, particularly renal dysfunction, et cetera, could be at higher risk. Again, it's always a weighing out, though, what's their risk of dying of breast cancer, too, you know, because we can always start at a lower dose with patients. But I think that, you know, even the larger T2N0s, we may want to give some consideration because, as we know, just the 4 doses of the T-DXd, the ILD rate was low, 4 or 5%. There was one death on both the ACTHP and the T-DXd THP arm from pneumonitis, one on each arm, so it wasn't 0, but the incidence of ILD was a lot lower with the 4 cycles, like 4 or 5%, compared to about 9+% in the 05 trial. So that is a good thing. But I think it's really the history of ILD or very substantial comorbidities that would increase their risk for ILD.
And talking about this adaptive approach again, are you theoretically concerned about patients receiving taxanes up front first, where we could have ILD with a taxane as well, or some pneumonitis? And then is that a theoretical concern? I've heard some of this from some community practitioners.
Yeah, I probably wouldn't do that likely. You know, I think if I'll probably make the decision, I probably would go with a DB11 or a DB05 strategy, probably. So if I thought they were pretty low risk, then I would go with probably a TCHP. But if on physical exam or imaging, I'm really concerned that they're not having a great response, you know, for example, then I would feel that then I would go with the T-DXd. I don't know that we have, that we know whether their risk of ILD will be worse, higher, right. Having had a prior taxane. What was reassuring in 05 was patients could get their radiation therapy post-operatively with the T-DXd or have before the T-DXd, and it didn't make a difference in terms of ILD risk or radiation pneumonitis risk. So that's good. So I'm not too worried about antecedent taxane. If I think somebody's low enough risk that they may not need the T-DXd, but if they don't have a good response, I would change midstream, as you had said.
Right. And in speaking about ILD, right, in this DB11, imaging was done every 6 weeks. Is this something that is practical for you? How will you approach monitoring in the neoadjuvant setting differently than you would in the adjuvant setting?
Yeah, and in the DB11, they were doing it every 6 weeks through the entire preoperative therapy, so the 4 T-DXd and the 4 THP. And they showed just a little over 2% risk of ILD with the 4 of the T-DXd during that period of time, but also a little over 2% for the THP. So like a little bit of a delayed effect, if you will. Or it could have been taxane-induced ILD too, because we know you have some of that too. We don't go looking for grade 1, but if we looked, we probably would find more grade 1 ILD from taxane. So we're going to need to do the every 6 weekly, and you know, it's the kind of thing where it is an extra burden on the patient. There's no question about that. I use non-contrast chest CT scans, and you know, whatever it takes, basically, to, I think we all have that approach in the early stage breast cancer, like whatever it takes, and because we got to have the safety and we got to have the efficacy.
That's right. That's right. So you mentioned 5% incidence in DB11, 4 cycles, 10% in the adjuvant setting. Is there anything that you do differently in the adjuvant setting?
Well, I think the imaging there was every 3 cycles there in DB05. I think it was every 3 cycles non-contrast, so that's pretty standard. And I think patients didn't, the median number, they got like 70-75% of their cycles. I think it was about 9 to 10 months of therapy. So they were a little shy. I think it was like 11, 12 cycles was about the median. So not all the patients are going to get all of the cycles, because you know, we get that cumulative fatigue, you know, that can, of course, we stop for any kind of symptomatic ILD, of course, but you know, fatigue can also be treatment limiting over time, although dose reduction really does help. Nausea, of course, with olanzapine, 2.5 to 5 milligrams at HS, that's made a huge difference starting the night of the therapy. But there can be cumulative toxicity. They're really getting in the way of people's function. These gals have been on therapy now a long time. You know, they've got to get back to life as well. And particularly if they just have like a RCB1 or a very little disease left, you know, that's really going to be we're going to individualize that, I think. Right.
And I think, you know, switching gears to DB05, that conversation now in the clinic, what does that look like for your patients, right? How will you differentiate that discussion, T-DXd as an option versus TDM1? How do you feel that's different in the clinic now?
So I think that conversation, that is, that's a easy one for me, because although you know, in DB05, you had to have residual disease in the nodes.
Correct.
Or you had to be inoperable up front. So the highest risk of the highest risk. But it's a huge 50% reduction in the risk of recurrence, including in the brain.
Right.
And so
Huge.
huge. But then do we apply that now to all residual disease patients who have maybe cleared their nodes or didn't have nodes in the first place? There's no treatment effect in the nodes, but they still have some residual disease. That's going into a low risk population, But I think with a 50% reduction in risk, I was looking at the Catherine data too. With the most recent update of Catherine, is a 7% risk of a brain metastasis, and that was even in patients who had that. Catherine, of course, was the big spectrum down to like millimetric disease left in the breast. You know what I mean? But you take all your Catherine patients. 7%, that's a high risk of brain recurrence, And so I think we're all very concerned about the brain, and we really don't have the tools in hand right now for the brain. And so I probably will apply the 05 data beyond the eligibility of 05 into the residual risk group patients and anybody who has residual disease.
And will there be a differentiator there for you at all, or will it be anyone with residual disease?
Probably so.
Or are you thinking only in the node, or a lot of disease in the breast? Maybe those are the patients, or really all, because you're convinced.
Yeah, I think the data are so striking that I probably will go with the T-DXd. I think so. I think, however, if they get a DB11 approach and they get the 4 cycles and the THP and they have residual disease, there it's a little bit more nuanced perhaps. If they have very little residual disease, then TDM1. If they still have substantial residual disease, and particularly I think if they started off with a large cancer, an inflammatory or a stage 3, but we saw really good results, and the T-DXd was working beautifully, because maybe 4 is not optimal for patients who have a lot of disease to start off with. And if we saw a really great response, and then they get their we stop at the 4 cycles, we go on to THP, but there's still residual disease, particularly in the nodes. I must say I'll probably be tempted to give the patients some additional 2 to 4 more cycles of the T-DXd, and then probably switch over, if I can, to the TDM1. I guess kind of hoping that there'll be some non-cross resistance with the TDM1. We don't know that post T-DXd. So we don't, but it's obviously a different payload, and particularly if the residual disease is HER2 positive. I know in Catherine that did not make a difference, but still, nonetheless, it doesn't have a bystander effect. You know what I mean? So I think that even though that's not how the studies were done, where if you got your 4 cycles of T-DXd and 11, then TDM1 was what the protocol, it was standard of care, and that's really TDM1 would be really the way to go. But that would be the only nuance, is people with very large cancers who had a very good response but still have residual disease. I might consider more T-DXd.
Let's talk about completion rates of both TDM1 and maybe some of your concerns surrounding the completion rates with T-DXd. What do you think would be the differences? What is it currently in your practice?
Well, in 05, it was about the same, too. There wasn't a big difference on both arms of the trial, because with TDM1, we do have to stop sometimes for thrombocytopenia or worsening LFTs, or just our older, frailer patients whose performance statuses are really being eroded, but even with dose reduction, they're still eroding or neuropathy. So we do have to stop it, I would say, before the end of the 14 cycles, maybe in 25% of patients, if I put it all together. And I think T-DXd will be very similar. The fatigue of T-DXd improves with dose reduction. Nausea rarely is something we really can't handle, although it's not zero. It's not zero. Sometimes we have to do even with our best therapies, we still sometimes have to do a dose reduction. That does help. But the fatigue can also be cumulative. And again, if we're eroding patients' functional status, it's going to also depend on how high risk they are, essentially. But I think it'll be very similar. I think that's what the 05 data showed.
And on a practical level, on the fatigue side, right, anticipating 14 cycles in the adjuvant setting, how do you manage that with your patients?
It's a lot. It's a lot. 10 months of therapy is a lot. And, in patients who do need a dose reduction, if we go from the 5.4 down to a 4.4, for example, their hair will usually grow back as well, which is good because it's a long time with alopecia. Because generally I find it doesn't grow back at the full dose, generally speaking. But it is a lot, but we face it now. T-DM1 is really, in general, so well tolerated.
Correct.
Once they get through couple 3 cycles, the body's adjusted, and there's that group that we do need to stop, but that's a minority. I think T-DXd is more toxic.
Yeah.
And so I think it may be a little bit more challenging. Thankfully, I think dose reduction will help.
And then you brought up alopecia. Do you think that that's going to be a barrier in our discussions in the clinic, right? Like a young woman who's like, I would like my hair to grow back. I want to move on with my life.
Yeah.
What is that conversation?
And I think in our scalp cooling techniques are really not that effective, with the T-DXd at the full dose. And hopefully, since the women may have alopecia by the time they go to surgery, depending on if they scalp cooled or not, but if they get 14 cycles of the T-DXd, that means they didn't get it preoperatively, because I do not think I would give 4 cycles preoperatively and then 14 cycles for residual disease. I don't see me doing that, because there's going to be possibly some degree of resistance in the residual disease. So I'll be interested in what I hope will be a non-cross resistant agent with the T-DM1. But if patients have not had alopecia because they've done scalp cooling because they got TCHP, for example, then that's really a discussion, and the hope would be that they would be willing to have some alopecia, or at least do the best they can on the scalp cooling, continue the scalp cooling, because it will help decrease the alopecia, at least to some extent.
I think like much of anything that we do is really preparing our patients, right? And saying to them, now that we have this approval, we know that this agent is likely to cause alopecia in the adjuvant setting, preparing them, setting them up for it. At this point, when I've presented it to patients, they're so impressed with the data that it's really hard to say no.
Mm-hmm. Right.
I think that's where we stand today.
Yeah, it is huge.
And to switch gears and conclude, let's talk about someone who progresses, right, and has metastatic disease and has been on either shortly after T-DXd in the adjuvant setting or on T-DXd. What is going to be your approach to first-line management of metastatic breast cancer, considering the impressive data with DB09?
Yes, with the pertuzumab added in there too, Certainly if somebody has a treatment-free interval longer than a year, then I would use the DB09. I'd go to the T-DXd and pertuzumab, first line metastatic. If they recur within a year, Mabel, my experience has been that is a biphenotypic cancer, where you've killed off a lot of the HER2 with your initial curative therapy, and the disease that comes back, I have found in general, isn't particularly responsive to HER2-directed therapies, particularly these basal HER2 admixtures are really bad cancers. Sometimes, unfortunately, we still have these false positive about 10-15% of the time, and particularly in the ER-positive breast cancers where there's a lower level of HER2 amplification. There can be overcalling, so we don't have the right diagnosis. So I become very, very aware of that, and I send anything I'm unsure of, I send to Dr. Michael Press at USC to redo it, to make sure I've got the right diagnosis. So I think a lot of these fast recurrences, honestly, are biphenotypic disease, or perhaps they weren't HER2 positive in the first place, basically, because I think that's really so unusual. I haven't had hardly any recurrences, with HER2 positive disease. I work really, really hard to make sure I have the right diagnosis, But I think if they are a year out, but in that situation that they have a very fast recurrence, it would be difficult because they will have already had, THP or TCHP and T-DXd. And so, you know what I probably would do, Mabel, I would think back on how well they did with the T-DXd if they got it preoperatively. And if they got it preoperatively only 4 cycles, then I would go back to it, I think.
Right. But maybe you'd consider maybe the HER2 CLIMO2 in the setting of progressing on T-DXd in that year.
Yes.
Right?
Yeah, absolutely. Yes, yeah.
And I imagine you screen everybody with the brain MRI up front, right?
I
How do you do that?
I have become more proactive because I've been burned, with people that present with brain metastasis, and had I looked earlier, they wouldn't be having a seizure, for example, or have to go right to surgery, which can seed their meninges. So I have become proactive because I think their outcomes are better if we catch these brain metastases before they're really symptomatic.
Right. Throw your curveball. Where do you think ctDNA in this whole landscape that is so evolving and changing, whether metastatic setting, whether in the neoadjuvant or adjuvant setting, where do you think it fits at all?
Yeah, I think right now we don't use it in practice, but looking at the crystal ball, a question's going to come up. If people get 4 cycles of T-DXd preoperatively and they basically go into a clinical complete response very, very quickly within a cycle or 2, well, they clear that ctDNA, and we may be able to de-escalate. Or even a THP approach. You do a THP approach for maybe a stage 2 disease, and if they are a clinical and maybe imaging CR and they've cleared that ctDNA, they go to surgery. So I think it's a de-escalation strategy. Right. We know for sure if they don't clear that ctDNA during neoadjuvant therapy, they're at very, very high risk. And certainly we would want to bring in the T-DXd. So I hope it'll be a way to de-escalate over time for patients who rapidly clear that ctDNA as we get more data that they really do extremely well.
So Joyce, thank you so much for this wonderful discussion. Your summary of the key takeaways from this discussion.
Well, we fortunately have the DB11 and the DB05 data. They're both strikingly positive studies. The FDA has given us broad labels for stage 2-3, for preoperative T-DXd, and for any residual disease for DB05, which is fantastic. We're not hamstrung by, wording on labels, et cetera. And I think that in general, HER2 positive breast cancer is still a very, very serious disease. We're not curing everybody. And I think in general, getting that path CR, both from a surgical standpoint and from a medical standpoint, is really what we really want to do. So I think in general, I'll be using T-DXd up front. There maybe the lower risk stage 2 patients that I'll go with a more classic TCHP route, knowing that if they have residual disease, I can still give them this phenomenal drug. So that's probably what I'll end up doing. And then the only other nuance is if they had stage 3 disease and I've only given them 4 cycles, they have residual disease, do we give them a little bit more or give them some more after surgery? I think that's still, look forward to talking to my colleagues as we all figure out how to incorporate this in our practice.
Absolutely. Very, very exciting times.
Yes.
Thank you so much for joining us this afternoon.
Thank you.
Thank you.